Now we will discuss the drugs used for psychiatric illness. Now psychiatric illness is broadly divided into two types. It can be psychosis. It can be neurosis. The basic difference between these two entities is insight. In psychosis, insight is absent, whereas in neurosis, it is present. Insight means awareness about the illness. A neurotic person knows that he is ill. He has some problem. So he will himself go to the doctor to get the treatment. Whereas a psychotic person do not know that he is ill. So a psychotic person will not accept treatment. So in this manner, it is relatively difficult to treat because the patient compliance is poor. Now the psychosis is further of two types. One is the major psychosis, which is also called schizophrenia. And second type of psychotic illness are called mood disorders. Disorders of mood, and the patient may have aggressive mood, violent behavior, which is called mania. The patient may have depressed mood, which is called depression, or the patient is alternating between the two, sometimes in mania, sometimes in depression. So that is called manic depressive psychosis. Because the person is having both the poles in the life, so it is also called as bipolar disorder. Now examples of neurotic disorders, they include generalized anxiety disorder. We have phobias, means fear of something, fear of height, fear of open spaces, fear of closed spaces. These are phobias. Another disorder is obsessive compulsive disorder. Then we have some eating disorders which are called bulimia. These are eating disorders. We have post-traumatic stress disorder. So all these are examples of neurotic disorders. So we will discuss the management of these disorders in psychiatric illness. And the first topic we will start is schizophrenia. The drugs used for schizophrenia are called antipsychotic drugs. Main psychosis is schizophrenia. So the drugs used to treat that are called antipsychotic drugs. As we discussed earlier, psychosis or schizophrenia, it is opposite to Parkinsonism. So major reason is it is due to excessive dopamine in the brain. So if we block the dopamine receptors, we can treat psychosis. So if a drug acts by blocking the D2 receptors, it is called as typical antipsychotic drug. So typical antipsychotic drug is that which act by blocking the D2 receptor. Now if a drug acts by any other mechanism, then it is called as atypical antipsychotic drug. And the most important among these is 5-HT2 receptor blocking mechanism. So if a drug mainly block D2 receptor, it is called typical antipsychotic. If a drug mainly block 5-HT2, it is called atypical antipsychotic. Now most of the drugs have both of these properties. So it will depend upon relative affinity of the drug for these receptors. So that is sometimes expressed as a blocking ratio of D2 blocking divided by 5-HT2 receptor blocking ratio. So if a drug has this ratio more than 1, the drug is called typical antipsychotic. If this ratio is less than 1, the drug is called atypical antipsychotic. So we'll start with the typical antipsychotic drugs. Typical antipsychotic drugs, they are of three types. First group is haloperidol group of drugs. The drugs like haloperidol, droperidol, and flufenazine type drugs. Second type of drugs are chlorpromazine group. The drugs like chlorpromazine, thioridazine, and third group is thiothiazide group. Drugs like thiothiazide, chlorprothiazine, now what is the method of classifying these is the first group of drugs, that means haloperidol like drugs, they are very strong D2 blockers, high potency D2 blockers. Second, drugs are very weak D2 blockers. And the third group is intermediate between the two. Now, if a drug is a strong D2 blocker, it is likely to be more efficacious antipsychotic drug. But the problem is, if a drug is blocking D2 receptors strongly, chances are there that it can block the receptor more than required also. So that means if we give haloperidol like drugs in overdose, it can block the receptor more than required. And if a receptor is blocked more than required, what will happen? Yes, Parkinsonism can occur. Now, not only Parkinsonism, they can cause a group of disorders which occur due to excessive dopaminergic blockade in the brain, and those group of disorders are called as extrapyramidal symptoms. In short form, they are called EPS. Parkinsonism is just one example of this. So first of all, we'll discuss little bit about these extrapyramidal symptoms. These include acute muscular dystonias, akathisia, Parkinsonism, tardive dyskinesia, and malignant neuroleptic syndrome. Malignant neuroleptic syndrome. So all these EPS, they are more likely with these strong drugs like haloperidol. Special points to remember about these drugs: most commonly seen extrapyramidal symptom is akathisia. Akathisia is most common extrapyramidal symptom. Then earliest extrapyramidal symptom to appear is muscular dystonia. It can appear even after few hours of giving haloperidol like drugs. Then latest to appear, the extrapyramidal symptom which is seen after many years of use is tardive dyskinesia. Now coming to the treatment of extrapyramidal symptoms, do you remember what is the drug of choice for drug-induced Parkinsonism? Yes, it is benzohexole, anticholinergic drugs. So benzohexole is drug of choice for Parkinsonism. Not only Parkinsonism, it is also the drug of choice for muscular dystonias. Now benzohexole can also be used for akathisia, and it can also be used for malignant neuroleptic syndrome. But for these two conditions, it is not the drug of choice. It can be used. The drug of choice for akathisia is propranolol, a beta blocker. And drug of choice for malignant neuroleptic syndrome is dantrolene, a muscle relaxant. Tardive dyskinesia, important to remember, anticholinergic like benzohexole is contraindicated. Benzohexole is contraindicated for tardive dyskinesia. Benzohexole is contraindicated.
Pathogenesis of tardive dyskinesia is different from other extrapyramidal symptoms. So basically what happens, mostly tardive dyskinesia, it occurs after we withdraw the antipsychotic drug. So what has happened actually is D2 receptors which were present here, they were blocked by antipsychotic drugs. So when chronically we block the D2 receptors, the supersensitivity occurs. That means the number of receptors increase. But because dopamine is not able to work, receptors are already blocked, so the action do not come. But what happens when we stop giving the antipsychotic drug, when we stop this D2 blocker, now this dopamine can stimulate so many receptors. So due to super sensitivity which symptoms come, they are called as tardive dyskinesia. Now what is important is, for all other extrapyramidal symptoms, the main reason is excessive D2 blockade. Whereas in tardive dyskinesia, the main reason is D2 super sensitivity. So mechanism is opposite. For all EPS, we can use anticholinergic drug. Remember, we want to restore the balance. For extrapyramidal symptoms, what is the problem? D2 receptors are blocked more than required. So if we decrease acetylcholine also, the balance will be restored. So anticholinergic drug like benzohexol can be used for all EPS, extrapyramidal symptoms. But in tardive dyskinesia, the problem is different. Dopamine working is more, super sensitivity is there, and if we give anticholinergic drug like benzohexol, then the balance will be shifted even more. So the symptom will aggravate. So benzohexol like anticholinergic drugs are contraindicated in tardive dyskinesia.
Recently, a new drug has been approved for treatment of tardive dyskinesia, and name of that drug is valbenazine. Valbenazine is the only drug which is approved for treatment of tardive dyskinesia. Valbenazine. So these are the important points regarding the extrapyramidal symptoms, and extrapyramidal symptoms are more likely with strong D2 blockers, and highest risk of extrapyramidal symptom is present in haloperidol. Haloperidol has highest risk. Chlorpromazine like drugs will have less risk of extrapyramidal symptoms, and the least risk is with thioridazine among the typical drugs. Now, apart from extrapyramidal symptoms, the second important thing is D2 receptors of dopamine in the pituitary, they are acting to decrease prolactin. The function of D2 receptor is to decrease prolactin. So when we stimulate D2 receptor, it will decrease prolactin. So if a drug like haloperidol, it acts by blocking D2 receptor, this action will not happen. That means the prolactin level will increase. So antipsychotic drugs can also cause hyperprolactinemia. Hyperprolactinemia. And again, this side effect will be more common with strong drugs like haloperidol. So haloperidol like drugs, they have high risk of causing extrapyramidal symptoms and hyperprolactinemia. Now, apart from these side effects, which are due to excessive D2 blockade in the brain, typical antipsychotic drugs also cause some extra side effects. These include, they have anticholinergic activity, they have alpha receptor blocking activity, they have antihistaminic activity, and they also can induce seizures. So typical antipsychotic drugs are not selective D2 blockers, they have many other actions also. So anticholinergic activity, it will lead to adverse effects like dryness, blurring of vision, urinary retention, and all the anticholinergic side effects we discussed. Alpha blocking activity can lead to hypotension. Antihistaminic activity in the brain can lead to sedation. And because they lower the seizure threshold, they can lead to seizures. So these side effects are also present with the typical antipsychotic drugs. But important thing, these side effects are more common with chlorpromazine and haloperidol, thioridazine like drugs, and less likely with haloperidol like drugs. So this fact you can remember easily, that typical antipsychotic drugs will cause some side effect. If we give a strong drug, it will cause extrapyramidal symptom or hyperprolactinemia. If we give a weak drug, it is likely to cause these type of side effects like anticholinergic alpha blocking like side effects. So typical drugs, problem with typical drugs, one, they have lot of side effects. Second problem with typical drug is they can control the violent behavior of a patient with psychotic disorder, which are called positive symptoms. but they are not able to control the depressive symptoms, which are called negative symptoms. So typical drugs are not effective against negative symptoms of schizophrenia. So because of these two reasons, one, to reduce the number of side effects, and second, we want to control negative symptoms also, we developed the second group of drugs, which are called atypical antipsychotic drugs. So atypical antipsychotic drugs have two advantages. One, they have lesser risk of causing extrapyramidal symptoms and hyperprolactinemia. Second, they are effective against both positive and negative symptoms of schizophrenia. And the drugs in this category include clozapine, olanzapine, quetiapine, acinapine, and zotapine. Then we have drugs like risperidone, paliperidone, iloperidone, ziprasidone, and lurasidone. So the name of these drugs you can remember. If you see carefully, the name of these drugs end with either pin or their name end with done. So you can say पीने का काम done. These are atypical antipsychotic drugs. Apart from these, there are some drugs which do not follow this nomenclature.
These drugs include aripiprazole, brexpiprazole, pimavanserin.
Atypical antipsychotic drugs. They have lesser chance of causing extrapyramidal symptoms and hyperprolactinemia. They are effective against both positive and negative symptoms of schizophrenia. But as a group, atypical antipsychotic drugs cause metabolic problems. Metabolic problem means they can cause hyperglycemia, hyperlipidemia, weight gain, and insulin resistance. Combined together, these symptoms are called lipodystrophy syndrome. Lipodystrophy syndrome. So atypical antipsychotic drugs can cause lipodystrophy syndrome, and the risk of this side effect is highest in clozapine and olanzapine. Clozapine and olanzapine, they have highest risk of causing lipodystrophy syndrome. Now, apart from lipodystrophy syndrome, clozapine has some more side effects which are very important to remember. The other side effects of clozapine, the most important to remember, it can cause agranulocytosis. Agranulocytosis. Clozapine can cause seizures, convulsions. It is also associated with myocarditis. Clozapine can also cause sedation. All these are adverse effects of clozapine, and important to remember, seizures are the dose dependent side effects. That means they will be seen only at high dose but not at low dose. Whereas agranulocytosis is dose independent. That means we cannot predict whether this will occur or not. Dose independent. Sedation is the most common adverse effect of clozapine. Most common adverse effect of clozapine is sedation.
Another common adverse effect of clozapine is siluria, or simply hypersalivation. Now, normally clozapine possesses anticholinergic activity, So they should cause a dryness, dry mouth should be there, but it causes siluria. In fact, this is the only important drug among the CNS drugs which cause siluria. Most of the CNS drugs cause dry mouth. Then clozapine, why it causes siluria when it is having anticholinergic activity? So exactly mechanism is not known, but it is assumed that clozapine block alpha 2 receptors and it stimulate M4 receptors. Apart from blocking M1 M3 receptors, clozapine block alpha 2 receptors and stimulate M4 receptors, and these two properties may be responsible for causing siluria. Clear? Now clozapine, it is a drug which has so many side effects. We discussed it can cause siluria, it can cause sedation, it can cause myocarditis, agranulocytosis, seizures, plenty of side effects are there. So we do not prefer to give clozapine, but it is very, very effective antipsychotic drug. So when the psychosis is not able to be treated by other drugs, then we will look at clozapine again. So clozapine, it is a drug of choice for resistant schizophrenia. So if the question is asked what is a drug of choice for resistant schizophrenia, then the answer is clozapine, because we do not prefer it normally because of side effects, but when we cannot treat by any other drugs, then we will look at clozapine. Okay.
Then we have a drug called quetiapine. This is associated with cataract. Quetiapine can cause cataract. Quetiapine can cause cataract. Then we have another drug which is called ziprasidone. Ziprasidone. It is associated with prolonged QT interval. That means it predisposes to torsades de pointes. Ziprasidone, it can cause prolongation of QT interval.
Now risperidone, it has maximum D2 blocking property among the atypical drugs. Remember, all the typical drugs block D2, but atypical mainly block 5-HT2 receptors. Risperidone has maximum D2 blocking potential. So among the atypical drug, it has maximum risk of causing extrapyramidal symptoms as well as hyperprolactinemia. So maximum risk of extrapyramidal symptom and hyperprolactinemia among atypical drugs is present with risperidone. Now coming to some of the new drugs like pimavanserin. Pimavanserin, this is a drug which is again atypical antipsychotic drug. It acts by blocking 5-HT2 receptors and it is specifically approved for treatment of psychosis in a patient with Parkinsonism. So Parkinsonism induced mental problems, it is the drug which is used, not the drug of choice. It is approved for treatment of that. So from the name you can remember P for Parkinsonism, I for induced, M for mental, A for anomalies. So it is used for treatment of Parkinsonism induced mental anomalies. So these are the important points regarding the new antipsychotic drugs. Now apart from psychosis, these drugs have many other uses, and the uses of antipsychotic drugs we can remember as antipsychotics. So anti stand for number one, anti-emetic. So remember, they block D2 receptors. D2 receptor cause vomiting. So D2 blockers will treat vomiting. But because of their plenty of adverse effects, we do not prefer them in vomiting. We use safer drugs like domperidone. But they have antiemetic property, and this is important to remember. Many times the question is asked, all of the following are side effects of haloperidol except. So we have discussed so many side effects, but be very careful, it will not cause vomiting because it has antiemetic property, so it will treat vomiting. So antipsychotic drugs do not cause vomiting. That is important to remember. Then second, on anti, you can remember these have anti-manic property. Antipsychotic drugs possess anti-manic property. In fact, antipsychotics are drug of choice for acute mania as well as they are drug of choice for bipolar disorder in pregnancy. Then Psy means psychosis. This we discussed. Antipsychotic drugs are used for schizophrenia or psychosis. Then another thing is chorea. Chorea means Huntington's chorea. Antipsychotic drugs can be used for treatment of Huntington's chorea, but the drug of choice for Huntington's chorea is tetrabenazine. Tetrabenazine is a drug of choice. Antipsychotics can be used. Then lastly, we have tics. First of all, what do you mean by tics? Tics are sudden repetitive contraction of a group of muscles. Like you must have seen some people, they keep on flashing their eyeballs. So that is a type of tic. So tics are sudden repetitive contraction of a group of muscles. And there is one syndrome in which these tics are seen. Yes, that is called as Tourette syndrome. Tourette syndrome. The full name of this syndrome is Guillain-de-la-Tourette syndrome. So this is a special type of syndrome in which there are vocal tics. Vocal tics are there. Means the muscles around the vocal cord contract and some sounds emerge. So most of the time these sounds emerged are not good. So these seem some abusive type of sounds. So that's why if you see the name in Hindi, we say Guillain-de-la-Tourette syndrome. Guillain-de-la-Tourette syndrome. Now, antipsychotic drugs like haloperidol, they can be used for Tourette syndrome. For Tourette syndrome, we can use antipsychotic drugs. But the drug of choice for Tourette syndrome also is tetrabenazine. Tetrabenazine is a drug of choice. Another drug which is very commonly used for Tourette syndrome, these are clonidine or guanafacin. Clonidine and guanafacin, they are commonly used drugs, most commonly used drug for Tourette syndrome. But tetrabenazine is a drug of choice for Tourette syndrome. Okay. So these are the important points regarding the antipsychotic drugs.
Now, second type of psychotic disorder are mood disorders. And we discussed we have three types of mood disorders: mania, depression, and bipolar disorder. Now, how a person of acute mania presents? Now, patient of acute mania is aggressive. The patient is very dangerous, violent, and in simple language, this person can kill anyone, and doctor is no exception. So what will be the treatment of or aim of treatment of acute mania? So in acute mania, aim of treatment will be to save our life. Only then we can treat the patient. So in acute mania, we have to first of all sedate the patient. So drug of choice for acute mania are sedative drugs. Sedatives are drug of choice. So commonly we use antipsychotic drugs along with benzodiazepines. Sedative drugs along with benzodiazepines are used. But sedative drugs will only make the person sedated. They have no effect on the mood. So we have to give some drug for mood also. And the drug which is used for mood is lithium. We cannot use only lithium because lithium takes 7 days to produce action. So it has to be supplemented with sedatives. So if you have to answer only one out of the two, then the answer will be sedative drugs. Now, after acute phase is over, when the mood has been stabilized, then we can stop antipsychotics or benzodiazepines and continue the patient on only lithium. If the question is asked what is drug of choice for prophylaxis of mania, then only lithium will be there.
Lithium is very important regarding MCQs. You should know each and every detail about lithium. So first of all, pharmacokinetics of lithium. Lithium is a drug which has almost 100% absorption. So when we give it orally, all the drug is absorbed. It has negligible plasma protein binding, almost 0%. So when we give oral tablet of lithium, in around 2 to 4 hours, peak levels are reached. Peak levels are reached in 2 to 4 hours. Next important thing, lithium has a half-life of 24 hours. And how it is removed from the body? Excretion. The major excretory organs are kidney. 95% of lithium is excreted unchanged by the kidneys. However, very important to remember, around 4% of lithium is also excreted by sweating. This is very important. We will cover later on why it is important. And remaining lithium can be removed in the feces, less than 1%. So these are the important pharmacokinetic things. Now, most important are actions of lithium, and that you can remember from the name itself, lithium actions. Actions of lithium you can remember from lithium actions. So we're discussing one by one. L for leukocytes, I for increase. So lithium increase the leukocytosis sites. It causes leukocytosis. It causes neutrophilia. This is very important because in pharmacology, with many drugs you must have read, this drug causes neutropenia. This drug causes bone marrow suppression. This drug causes agranulocytosis. But you very rarely read that this drug causes leukocytosis. So drugs causing leukocytosis are very important to remember, and lithium is the one drug which causes leukocytosis. Apart from these two more drugs you need to remember, one is hematopoietic growth factors, WBC growth factors, GCSF, GMCSF. Obviously they can increase WBCs. And third very important are corticosteroids. So lithium, steroids and growth factors, they cause increase in WBCs, leukocytosis. Most other cause leukopenia. Clear? Then T for tremors. Tremors are the most common adverse effect of lithium therapy. In normal therapeutic concentration, it may cause fine tremors, but whenever overdose occur, toxicity occur, it can result in coarse tremors also. Then H for hypothyroidism. Lithium inhibits the secretion of thyroid hormones from the thyroid gland into the blood. So when the hormones do not come in the blood, it can lead to hypothyroidism. Then I for increase and U for urine. So lithium can cause polyuria. It can even lead to diabetes insipidus. Now how this happens? If we see the cells of the collecting tubule, they contain a pump called as epithelial sodium channel on the luminal side. This is the lumen, this is blood side. So the pump present here is sodium channel, epithelial sodium channel. So through this channel normally sodium enters. So after the entry of the sodium, another channel is present on the basolateral membrane, which is sodium potassium pump. So through this pump, sodium comes into the blood. So this is the method how sodium comes into the blood. From the lumen through epithelial sodium channel, it comes in the cell, and then from the epithelial cell, it goes into the blood via sodium potassium pump. Now lithium, it can enter from the same pump. So lithium enters through the epithelial sodium channel. But lithium cannot go out through the sodium potassium pump. So what happens? Lithium enters the epithelial cell but cannot leave. So lithium will accumulate. So lithium accumulate in the collecting duct cells. Now after accumulation, lithium inhibit an enzyme called as glycogen synthase kinase 3 beta. So when this enzyme is inhibited, it results in decreased activity of vasopressin. So when vasopressin is not able to work, it results in diabetes insipidus. So lithium can cause nephrogenic diabetes insipidus. Now, how we can stop this? We know that lithium enters through the epithelial sodium channel. So when lithium is entering through this channel, if we block this channel, lithium will not be able to enter. So when lithium do not enter, we can treat diabetes insipidus. Yes. So which drug inhibit epithelial sodium channel? Right, it is amiloride. So amiloride, it is used for treatment of diabetes insipidus caused by lithium. Clear? Then lastly, M for mothers. Lithium should be given carefully in expectant mothers, means in pregnancy, because it is teratogenic. If lithium is given during pregnancy, particularly the first trimester of pregnancy, the baby will be born with a congenital anomaly called Epstein's anomaly. And what is Epstein's anomaly? Yes, it is characterized by congenital tricuspid atresia. So lithium can cause congenital tricuspid atresia. But the problem is controlling bipolar disorder is also very important. So if other drugs are not able to manage, we have to give lithium. So if we give lithium during pregnancy, one problem is it can cause congenital malformation, teratogenicity. But the lithium can easily cross placenta, so other side effects can also be seen in the baby. So if lithium is exposed to the baby, so what all problems can occur? It can cause congenital hypothyroidism. Remember, the same thing which it do in mother can be done in baby also. Hypothyroidism can occur. Lithium can result in CNS depression. The baby may be born with CNS depression. It can result in a special problem called as hypotonia. Baby may have severe hypotonia, also known as floppy baby syndrome. So if lithium is given during pregnancy, the baby may develop floppy baby syndrome. And lastly, it can obviously cause cardiac murmurs because of congenital heart problems. So all these can be seen if baby is exposed to lithium in pregnancy. So one important problem or important suggestion is before delivery, around 1 to 2 days before delivery, that means 24 to 48 hours before delivery, we should stop lithium therapy. Lithium should be stopped minimum 24 to 48 hours before delivery. Clear? Now coming back, leukocytosis, tremors, hypothyroidism, polyuria or diabetes insipidus, and teratogenicity. These we have already covered. Now coming to A for acne. So lithium can worsen acne. If a person is already having acne, lithium therapy may worsen. C for calcium. Lithium may result in hypercalcemia by causing hyperparathyroidism. Lithium can cause hyperparathyroidism that can result in hypercalcemia. Then T stand for T wave changes in ECG. Lithium basically causes flattening of T waves, but these are benign, not of any clinical significance, and these are reversible. They will automatically stop. Benign and reversible T wave flattening may occur. But in toxicity, lithium can depress the heart, and in severe toxicity, it can cause severe bradycardia. Bradycardia can occur, and it can also result in AV block. So these can be seen in severe toxicity. Then I means incoordination. Lithium can result in incoordination, ataxias, slurred speech. These problems can occur. But these occur when the plasma level is highest, peak level. So we can avoid these problems by giving lithium at bedtime. So if we give lithium at the bedtime, the peak level will be occurring during sleep. So we can avoid these problems. Then O means obesity. Lithium causes significant weight gain. This is important. Lithium causes significant weight gain. Then N for nausea, vomiting, and diarrhea. GIT problems. Normally, almost any drug can cause GIT problem, but it is important in lithium because if a person develops vomiting and severe diarrhea, these are pointing toward lithium toxicity. So we should be careful. Lastly, S for seizures. So lithium can cause seizures in overdose. So these are the major actions of lithium. Very, very important. You can remember as lithium actions. Okay. Next is interactions of lithium. These are very important. One thing basic to understand is in the periodic table, lithium is present in same group as sodium. So kidney cannot differentiate between sodium and lithium. So kidney handles lithium the same way as it handles sodium. Like suppose a person develop dieting. Person is on fasting. Do not take sodium for 1 or 2 days. So what will happen when sodium is less in the body? Body will try to conserve sodium. So kidney increase the reabsorption of sodium. As kidney cannot differentiate between sodium and lithium, so it also increase the reabsorption of lithium. So when more lithium is reabsorbed, means more lithium is retained, that increase the risk of lithium toxicity. Okay? So it is very important. The person who is on lithium therapy is instructed to regulate the sodium level in the diet. Person is instructed not to do fasting, otherwise there may be lithium toxicity. Clear? Second, we discussed around 4% lithium is excreted in sweat. If a person is on lithium therapy and person develop extreme sweating, so lithium can be present in this sweat, and lithium is excreted in this sweat in preference to sodium. Normally sodium goes in this sweating, but now lithium goes in this sweating. So sodium is not going. So when the person develops sweating, the person will become thirsty. The person will drink water. So if we take only water without sodium, only water is taken. Sodium is already normal in the body because it is not excreted in the sweat. So if the sodium is taken, the water is taken, it will dilute sodium. Hyponatremia it will. So when sodium level decrease in the body, what kidney will do? It will conserve sodium. In that process, it will conserve lithium also. So when lithium reabsorption is stopped, that can result in lithium toxicity. So it is very important, if a person on lithium therapy develops sweating, person is instructed not to consume only water. Person is instructed to consume the water with sodium. Okay? Then third, obviously, interaction is with the drugs. So drugs, particularly thiazides, they do the same thing. Thiazide cause loss of sodium. So body try to conserve sodium. So it try to conserve lithium also. So lithium reabsorption increase, that can lead to toxicity. Another two drugs are lisinopril and indomethacin. These do alteration in the renal function, and they also help in retaining of lithium, which can lead to lithium toxicity. So lithium toxicity can be precipitated by three important drugs. You can again remember them from lithium. So Li for lisinopril, TH for thiazides, and I for indomethacin. They increase the risk of lithium toxicity. Okay. Now moving to very important thing about lithium is its plasma levels. We discussed already the half-life of lithium is 24 hours, 1 day. And we know the steady state concentration of a drug is achieved in how many half-lives? Yes, 5 half-lives. So lithium steady state will be achieved in 5 days. So we should monitor the plasma level of lithium after 5 days of starting the therapy, or whenever we change the dose of lithium, we have to monitor after 5 days. But at what time of the day we will take the blood sample? So it should be taken at trough level. Blood sample is taken at trough level. Trough level means 12 hours after giving the last dose. The person is taking lithium for 5 days. So on the 5th day, whenever the person has taken lithium, after 12 hours, we should take the blood sample. Clear? Now, what are the plasma concentrations required? For acute mania, the plasma level is 0.8 to 1.2 milli equivalent per liter. Whereas for prophylaxis of mania or for bipolar disorder, the plasma level required is lower. It is 0.5 to 0.8 milli equivalent per liter. You can see how narrow concentration range it is. If we increase the concentration, toxicity may occur. The symptoms of toxicity start at 1.5 milliequivalent per liter, and hospital admission is required at 2 milliequivalent per liter. So usually toxicity we assume when the plasma concentration is more than 2 milliequivalent per liter. Clear? Now what will happen in toxicity? In toxicity, obviously there will be symptoms, and the major symptoms pointing toward toxicity are GIT and CNS symptoms. GIT we already discussed, there will be vomiting and severe diarrhea, and CNS there will be ataxias, incoordination, and even tinnitus may develop. So whenever these symptoms are present, diarrhea and ataxias etc., it points toward toxicity. Yeah? So we should immediately take the measures to stop toxicity, and there is no antidote for lithium. So we can do hemodialysis if lithium has to be removed. Clear?
So these are the important points regarding the lithium.
Moving to mechanism of action of lithium. Now important to remember, lithium, it not only controls mania, but it can also control depression. Now here the basic thing to remember is mania and depression are not opposite diseases. Although the symptoms are opposite, but the diseases or the pathogenesis is not opposite. Mania occurs mainly because of overactivity of neurotransmitters in the brain, particularly the neurotransmitters which act through calcium. So in mania, those neurotransmitters are overactive, more of calcium is released, so the brain gets stimulated. But in case of depression, the pathogenesis is that in depression there is a deficiency of brain-derived neurotrophic factor, BDNF. This is a substance which is required for neuronal plasticity. Neuronal plasticity means that we know after birth the neurons do not divide, but the neurons, they will keep on forming the connection with other neurons. So when we are forming the connection with other neurons, this is called as neuronal plasticity. So if lot of connections are there, the person will remain happy. If the connections are not there, person get depressed. So brain derived neurotrophic factor is required for neuronal plasticity. Yeah? So lithium can treat both mania as well as depression. So we'll discuss one by one mechanism, how it treat mania, how it treat depression. So first of all, mania. We have given some neurotransmitter. It stimulates a G protein coupled receptor. When G protein coupled receptor is activated, it will activate a G protein called as GQ protein, which work through calcium. And this GQ, the active component of GQ, it will convert phosphatidyl inositol bisphosphate to inositol triphosphate, that means IP3, and diacylglycerol means DH. And this IP3, it is required for increasing the calcium. And when calcium increases, the action occurs. The problem in mania is this neurotransmitter is working more than required and lot of calcium is getting produced, and that will cause overactivity in the brain. Okay? So this has happened. After this, what happened is IP3, after increasing the calcium, it will be metabolized. So IP3 is metabolized to form IP2. With the help of a phosphatase enzyme, one phosphate group is removed. Then IP2 is further metabolized to form IP. One more phosphate group is removed. Then inositol phosphate is metabolized to form inositol. One more phosphate group is removed. Then this inositol will attach the phosphatidyl group, which result in formation of phosphatidyl inositol. Now this will start getting phosphorylated. Phosphatidyl inositol is converted to phosphatidyl inositol monophosphate, and this will be converted to phosphatidyl inositol bisphosphate. So basically what has happened is IP3, after producing the action, it has regenerated the PIP2 so that it can be utilized again. Clear? You understand the basic thing? Neurotransmitter produce the action. After the action, again the second messenger PIP2 is regenerated so that more calcium can be produced. So what lithium does? Lithium inhibit these phosphatase enzymes. Lithium inhibit the breakdown of IP2 and IP. So when these phosphate groups are not broken, that means this recycling procedure is not completed. That means PIP2 is not regenerated. So when it is not regenerated, then calcium will not increase, and when calcium do not increase, the mania is controlled. Clear? So in mania, lithium act by inhibiting the phosphatase enzymes. Okay. Now coming to depression. How lithium works in depression? So we discussed brain derived neurotrophic factor. It is required for depression. Now this factor after some time is metabolized, and it is metabolized by an enzyme called as glycogen synthase kinase 3 beta. Glycogen synthase kinase 3 beta. Lithium inhibit this enzyme also. So by inhibiting this enzyme, lithium inhibit the breakdown of BDNF. So that means BDNF, when it is not broken, the level will increase. And when the level of BDNF increases, neuronal plasticity occurs, and that will reverse the depression. Okay? So basically, lithium can be used to treat both mania as well as to treat depression. Okay. Now coming to uses of lithium. So lithium we just discussed, it can be used for acute mania. But when we use in acute mania, it must be complemented with the sedative drugs like antipsychotics. Then it can be used for bipolar disorder. For bipolar disorder, lithium is a drug of choice. Lithium can be used for even depression. Unipolar depression also we can treat with lithium. And lithium, it increase the leukocytes, although not commonly used, but theoretically we can use lithium for treatment of neutropenia, although it is not used because of so many side effects. So these are uses of lithium. Now moving to bipolar disorder. As the name tells, in this condition person has both poles in the life. Sometimes the person is in mania, sometimes the person is in depression, but sometimes the person is normal also. So when the person is in mania, we will treat like mania. Whenever the person is in depression, we will treat like depression. But when the person is normal, will you like to give any drug? Yes, we give the drug at this time to prevent person from going into mania or depression. This is known as treatment of bipolar disorder. So treatment of bipolar disorder itself means we want to prevent mania or depression. Okay? So bipolar disorder, we can give a drug to prevent mania, or we can give a drug to prevent depression. And we all know drug of choice for prophylaxis of mania is lithium. Lithium is drug of choice for prophylaxis of mania. But some other drugs are also used to prevent mania. The important among them are some anti-epileptic drugs. Anti-epileptic drugs like carbamazepine or valproate or even topiramate. They can be used for prophylaxis of mania. Another group of drugs are antipsychotic drugs. Now, what is important is drug of choice for prophylaxis of mania or simply drug of choice for bipolar disorder is lithium. Carbamazepine, valproate or topiramate can be used. But special point about valproate to remember, it is a drug of choice for rapid cyclers. For rapid cyclers, drug of choice is valproate. First of all, what do you mean by rapid cyclers? Normally, this person who is shifting from mania to depression, mania, normal, depression, normal, mania, normal, depression, keep on changing. So most of the people, they have these cycles from mania to normal to depression to normal to mania. So this is one cycle. So most of the people, they have one cycle in a year or maximum 2 cycles in 1 year. But if a person has more than 4 cycles in 1 year, that person is known as a rapid cycler. And the drug of choice for rapid cyclers is valproate. Clear? Now, special point to remember about antipsychotics. If you see, we know lithium is contraindicated in pregnancy because lithium causes abstinence anomaly. All anti-epileptic drugs are also teratogenic. So special point about antipsychotics is they are safe in pregnancy. So they are drug of choice for bipolar disorder in pregnancy. Bipolar disorder in pregnancy, drug of choice are antipsychotic drugs. Okay, so these are the important drugs which are used to prevent mania. Now, for prophylaxis of depression, the most important drug we use is again lithium. Remember, we discussed just a little while earlier, lithium can prevent mania as well as depression. So drug of choice for preventing the depression also is lithium. In fact, lithium is the only drug which can prevent the risk of suicides in a patient with bipolar disorder. Remember, many atypical antipsychotic drugs, they can decrease the risk of suicide in psychosis, in schizophrenia, but they cannot decrease the risk of suicides in bipolar disorder. The only drug which decreases the risk of suicides in bipolar disorder is lithium. So drug of choice for bipolar disorder overall will become lithium because it will treat mania also and depression also. Okay. Then second, one more drug can be used to prevent depression in bipolar disorder. It is lamotrigine. Remember, other anti-epileptic drugs are mainly used to prevent mania, but lamotrigine can prevent depression, but it is not able to prevent the risk of suicides. Clear? So these are the important points regarding the bipolar disorder also. Okay, so now we will move to depression. Little while earlier, we discussed that depression occurred due to deficiency of BDNF. So when we increase BDNF, we can treat depression. But problem is, few years ago, a theory was made that depression occurs due to deficiency of monoamines in the brain. Monoamines, most important being serotonin. Little less important than serotonin is noradrenaline, or very little action by dopamine. So deficiency of these monoamines can cause depression. But now we are saying that depression occurred due to deficiency of BDNF. So earlier we had made a lot of antidepressant drugs based on this theory. So how we will explain that now we have suddenly changed the theory? So we have not changed the theory. We have just added the missing link. So what is the link is when these monoamines increase in the brain, they will lead to production of BDNF, and when BDNF increases, that will cause neuronal plasticity, and when plasticity occurs, that will prevent the depression. Okay? So basically everything is same. The only difference is we have added BDNF in between. So all the drugs which we discussed earlier, which are based on monoamine theories, they still remain valid. So in simple language, we can say if a drug increases serotonin or noradrenaline, or we say monoamines in the brain, it can be used to treat depression. Okay? So if we move to antidepressant drugs, so one simplest method of treating the depression is to increase serotonin in the brain. We know depression occurs due to deficiency of serotonin. If we increase serotonin, we can treat depression. So the drugs which act by increasing serotonin, they are called as typical antidepressant drugs. So their main mechanism is to increase serotonin. But anything in brain is not so simple. We said that serotonin increases, depression treated. There may be many other methods. And there may be some methods or some mechanism which we do not know still now. So any other method by which we treat depression, the drug is called as atypical. So typical antidepressant drugs are those which act by increasing serotonin, and atypical are those which act by any other mechanism. Clear? So we will start with the typical antidepressant drugs.
So for this, we need to know how serotonin is produced and works. So this is a neuron in which serotonin is produced and stored. So when the nerve impulse comes, serotonin is released. Then it works on receptors. Now we have to stop the action, and the action will be terminated by reuptake. The main method of termination is reuptake. This is very similar to the one which we discussed in sympathetic system. So in sympathetic system, same thing happens. That means noradrenaline, it is produced and stored. So when the nerve impulse comes, it is released. It works on the receptors, and then it is reuptaken. That is the main method of termination of action. Now, apart from reuptake, serotonin action can also be stopped by metabolism. Serotonin can be broken by monoamine oxidase type A. We have two types of monoamine oxidase A and MAO-B. MAO-A metabolizes serotonin. So we want to increase the level of serotonin for treatment of depression. We have two options. One option is we can inhibit the reuptake. Second option is we can inhibit the monoamine oxidase enzyme. So two types of typical antidepressant drugs will be one MAO inhibitors, MAO-A inhibitors, and second reuptake inhibitors. Starting with MAO inhibitors, the drug acting by inhibition of monoamine oxidase A is moclobemide. This is the only MAO inhibitor which is reversible. All other MAO inhibitors, they are irreversible. So moclobemide is sometimes known by a short name called as RIMA. RIMA stands for reversible inhibitor of MAO-A. So moclobemide, it can be used to treat depression. On the other hand, reuptake inhibitors, they may be of two types. One which inhibit the reuptake of only serotonin, and second which inhibit the reuptake of serotonin as well as noradrenaline. So two type of reuptake inhibitors. One non-selective, that means it inhibits the reuptake of serotonin and noradrenaline. So when reuptake of both is inhibited, the level of both will increase. The second type of reuptake inhibitor is selective. That means it inhibits the reuptake of only serotonin So that will increase only the level of serotonin and not noradrenaline. So what will be the clinical difference between these two drugs? The difference is, if a drug increase noradrenaline, that means it is increasing sympathetic activity. So that will lead to tachycardia and increased work of heart. So this drug will worsen the cardiac patient. So non-selective drug is avoided in cardiac patient, like hypertension, angina can be worsened by these drugs. On the other hand, selective drug do not increase noradrenaline. So there will be no problem in cardiac patient, so it is safe. On the other hand, a non-selective drug increase serotonin as well as noradrenaline. So it is likely to be more effective than selective drug. So a non-selective drug is indicated in severe depression, whereas a selective drug is indicated in mild to moderate depression. It is not used for severe depression. It is indicated for mild to moderate depression. So with this basic framework, now we can discuss the drugs separately, starting from non-selective reuptake inhibitors. Non-selective reuptake inhibitors. These are further of two types. One group is called as TCA. Full form is tricyclic antidepressants. The second group is SNRI, that means serotonin noradrenaline reuptake inhibitors. So we'll start from the tricyclic antidepressants. The tricyclic antidepressants and the related drugs, they include imipramine, desipramine, clomipramine, amitriptyline, and nortriptyline. These drugs inhibit the reuptake of serotonin and noradrenaline. So two important points which we have already covered. All of these drugs, they are effective in severe depression, but they are avoided in cardiac patients. In cardiac patients, we will not like to use them. Now, apart from this problem, all the tricyclic antidepressants, they have same side effects as we discussed in typical antipsychotic drugs also. That means they have anticholinergic properties, they have alpha blocking property, they have antihistaminic property, and they also can induce seizures. And these side effects are very prominent with the tricyclic antidepressant. Apart from these, tricyclic antidepressant drugs are also associated with arrhythmias. They can cause arrhythmias also. And in overdose, these can result in metabolic acidosis. In nutshell, antidepressant drugs which are tricyclic antidepressants, they are very toxic drugs, and slight overdose may result in death of the person. So because of so many side effects, these drugs are not preferred now. Previously, they were drug of choice for severe depression, but nowadays they are not preferred because we have so many adverse effects with tricyclic antidepressants. The second group of non-selective drugs are called SNRI, serotonin noradrenaline reuptake inhibitors. Now this group of drugs, they inhibit the reuptake of serotonin and noradrenaline. This is also done by TCAs. So how they are different from TCAs? SNRIs, they inhibit the reuptake of only serotonin and noradrenaline. They do not do anything else, means they increase the level of serotonin and noradrenaline, but they do not possess the side effects of tricyclic antidepressants like anticholinergic action or metabolic acidosis or other problems. So the advantage is they are effective in severe depression, but they are not lethal. They are not that much toxic. So due to this reason, these are drug of choice for severe depression. SNRIs are drug of choice for severe depression, And the drugs in this group include venlafaxine, duloxetine, milnacipran, desvenlafaxine, and levomilnacipran. These are examples of SNRI, serotonin noradrenaline reuptake inhibitors, and these are drug of choice for severe depression. So that is about the non-selective reuptake inhibitors. So now we will move to selective drugs. Selective drugs, the full name is selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. So as the name tells, they will inhibit the reuptake of only serotonin. They do not inhibit the reuptake of noradrenaline. So that means they are safe in cardiac patients, but we cannot use them in severe depression. They are mainly used for mild to moderate depression. The examples of SSRIs are fluoxetine, paroxetine, fluvoxamine, sertraline, citalopram, and escitalopram. These are examples of SSRIs, and these are considered to be very safe drugs. So due to this reason, SSRIs are drug of choice for mild to moderate depression. So if in the exam question asked is what is drug of choice for depression, you should mark SSRI. If they ask severe depression, they will specifically mention severe depression. So unless they ask severe, the answer should be SSRI. Now apart from depression, SSRIs are drug of choice for all neurotic disorders also. All neurotic disorders like phobia, bulimia, obsessive compulsive disorders, the drug of choice are SSRIs. So SSRIs are drug of choice for depression as well as all neurotic disorders. So these are the important points regarding the typical antidepressant drugs. So now there are some atypical antidepressant drugs also. Atypical drugs. These have some other mechanism. They do not mainly increase serotonin. They have some other mechanisms to treat depression. Some of the examples of atypical drugs are bupropion, amyneptine, tianeptine, mirtazapine, amoxapine, atomoxetine, mianserin. These are examples of atypical antidepressant drugs. Some of the important points to remember about these drugs are bupropion. It is used as an anti-smoking drug. Amyneptine and tianeptine, they instead of inhibiting, enhance or increase the reuptake of serotonin, but still they are used as antidepressant. The exact mechanism is not known. But if the question is asked which of the following is selective serotonin reuptake enhancer, not inhibitor, enhancer, then the answer is amyneptine or tianeptine. Now amoxapine is an antidepressant drug which has additional D2 receptor blocking properties. additional D2 receptor blocking property means it also act as antipsychotic drug, and it also can cause same side effect which are caused by D2 blockers. That means extrapyramidal symptoms and hyperprolactinemia. So amoxapine is an antipsychotic with antidepressant properties. Atomoxetine is indicated in attention deficit hyperkinetic disorder.
Now coming to mirtazapine. Now this is a drug which is known as NSSA. NSSA means noradrenergic and specific serotonergic antidepressant. NSSA is noradrenergic and specific serotonergic antidepressant. First of all, we will try to understand the mechanism. Then we will come to this name again. So what happens with mirtazapine is, so there are two neurons, one containing noradrenaline, second containing serotonin. So mirtazapine increase the level of both noradrenaline as well as serotonin. It increases both of them in the synapse, noradrenaline as well as serotonin. This noradrenaline can act on whatever receptors is available, alpha receptor, beta receptor, whatever available, they can be stimulated. But serotonin, it is not able to act on all the receptors. The reason being, suppose here 5-HT1 receptor is there, 5-HT2, 5-HT3, 5-HT4 receptors are there. So what it does is, it will block 5-HT2, 5-HT3, 5-HT4 receptors also. So that means it increases serotonin, but serotonin works only on 5-HT1 because other receptors are blocked by mirtazapine. So what happens when we give mirtazapine? It increases noradrenaline. It can work on all the receptors. It increases serotonin also, but it selectively work on 5-HT1 receptors. That's why the term is noradrenergic and specific serotonergic antidepressant. That means it increases noradrenaline and serotonin, but serotonin specifically work only at 5-HT1 receptors. Now, what is the advantage of this property is, it is assumed that the sexual side effects of SSRIs, they are mainly because of stimulation of 5-HT2, 3 or 4 receptors. So when serotonin is not working on them, then it will not lead to sexual side effects. So mirtazapine has lesser risk of causing sexual side effects as compared to other antidepressant drugs. Clear? Now, second thing, it increases noradrenaline and serotonin, but it do not inhibit their reuptake. Mirtazapine do not inhibit reuptake. Rather, what mirtazapine do is, we know that here presynaptic receptors are present which act like a brake. We have alpha-2 receptor here which is called autoreceptor. We have alpha-2 here which is called heteroreceptor. The function of both of them is to act like a brake. That means this alpha-2 is acting like a brake to noradrenaline and this alpha-2 is acting like a brake to serotonin. So what mirtazapine do is, mirtazapine block these alpha-2 receptors. So when alpha-2 receptor is blocked, the brakes fail. When a noradrenergic neuron brake fails, noradrenaline increase. When serotonergic neurons brake fail, then serotonin increases. Now, in addition, it has blocked 5-HT2, 3 and 4. So that will lead to, for the serotonin to work only on 5-HT1. So that's why it is noradrenergic and specific serotonergic antidepressant. Clear? Now, if we revise, mirtazapine, it acts by blocking alpha-2 receptor. So that will increase serotonin and noradrenaline. Then in addition, it block 5-HT2, 3 and 4 receptors. So serotonin will act on only 5-HT1 receptors. That's why it is called as NSSA. Okay. Now from the name you can remember these things. NSSA look like nasha. If in Hindi, if you study NSSA, if we study it become nasa. So the name says ताजा पीन, तो ताजा ताजा पीने से नशा हो जाता है, तो मिर्ट ताजा पीन it cause nasha, NSSA. Okay. Now further, from the name also you can remember that which receptor are blocked to increase noradrenaline and serotonin. So if we see, the name contains AZA. So if we write AZA, so it look like A2A. So you can remember alpha 2 antagonist. So it is alpha 2 antagonist. Okay? So these are the important points regarding the mirtazapine. Okay. So now we will move to two new antidepressant drugs which have been recently approved. First of them is S-ketamine. S-ketamine. So as the name tells, it is the S isomer of ketamine. It is assumed to act by blocking the NMDA receptors of glutamate. S-ketamine acts by blocking NMDA receptor of glutamate. It is given as a nasal spray for depression. S-ketamine is approved for depression. It acts as a nasal spray. Clear? The second drug is brexanolone. Brexanolone, it is a neurosteroid. Other name is allopregnanolone. This drug is recently approved in depression, but a special type of depression which is called as postpartum depression. So brexanolone is approved for postpartum depression. Okay? So these are the important points regarding the antidepressant drugs. Okay.